Good morning. Today my presentation will be about the dilated cardiomyopathy. To start with the epidemiology of dilated cardiomyopathy, we have a stable incidence for dilated cardiomyopathy and a growing prevalence. To have a stable incidence and the prevalence increasing, this means that we have an improved survival. The incidence is different across the world. For example, in Japan is 14 patients, in Europe and North America is 36 patients, and in South America and Africa it's more than 40 patients per 100,000 individuals. This variation is due to the genetic predisposition in case of dilated cardiomyopathy. So the genetics play a role for the different incidence from one continent to another. After this, we can talk about the prevalence of dilated cardiomyopathy among the different cardiomyopathies. Dilated cardiomyopathy is the second most prevalent cardiomyopathy after hypertrophic phenotype. The least common is the restrictive, 2%, and slightly more than this is the arrhythmogenic right ventricular cardiomyopathy. As we explained about the prevalence is increasing and incidence is stable, so the mortality trends between 1990 and 2017, there was a global trend to decrease, increase survival. So dilated cardiomyopathy is an important cause of morbidity and mortality. The principal cause of morbidity and mortality in dilated cardiomyopathy is heart failure. So patients with dilated cardiomyopathy have heart failure with reduced ejection fraction or mid-range ejection fraction, and this causes the morbidity and mortality. At the same time, advanced heart failure in dilated cardiomyopathy is one of the leading indications for heart transplantation. Actually, dilated cardiomyopathy is the most common indication for transplantation in children and young adults. In this presentation, I will depend on this position paper from the European Heart Journal, Heart Failure in Cardiomyopathy, a position paper in 2019. But this position paper talked about all the types of cardiomyopathy, hypertrophic and restrictive, but for the sake of time, we will talk only today about the dilated cardiomyopathy. The clinical presentation of dilated cardiomyopathy usually between the age of 20 till the age of 60 years. It's more prevalent in men, and the most common clinical presentation is heart failure. In 19% of the cases, dilated cardiomyopathy present with arrhythmia and arrhythmia only, and 15% others. I mean by arrhythmia that the patient does not have dilatation and does not have hypocontractility, and later in life he may develop or may not develop heart failure manifestations with impaired ejection fraction. Regarding the etiology of dilated cardiomyopathy, we will discuss in detail the genetic causes with the different mutations and the neuromuscular disorders. We will describe the viral infections responsible for the etiology of dilated cardiomyopathy. And in this category, we will talk about whether viruses are a real causative agent for dilated cardiomyopathy, or the viruses are just an innocent bystander, and we find them in the biopsies of the autopsies of the hearts of dilated cardiomyopathy patients, but they actually do not cause dilated cardiomyopathy. We will talk about this in details. We will just mention the systemic immune disease and the drugs and the alcohol and the endocrine like diabetes. And we'll talk a little about the peripartum cardiomyopathy. As we know, the peripartum cardiomyopathy is a big topic and needs a separate session alone. So to start with the etiology and to start with the genetic causes of dilated cardiomyopathy, this is an important cause for dilated cardiomyopathy. This is an interesting paper review series from the European Society of Cardiology 2 years ago. It's named Complex Roads from Genotype to Phenotype in Dilated Cardiomyopathy. So in this paper, they divided the dilated cardiomyopathy into two main categories. The first one is as inherited cardiac condition. What does this mean? This means that we will study the genes that are involved in the dilated cardiomyopathies, the gene mutations that cause dilated cardiomyopathy, and whether these genes only lead to one phenotype or overlapping phenotypes, meaning is a gene mutation leads only to one phenotype, example, dilated cardiomyopathy, or one genotype can lead to more than phenotype. For example, one mutation can cause dilated or restrictive or hypertrophic. We will talk about this in details. After this, we will talk about the relation between gene mutations and acquired conditions, meaning that a gene mutation in a genetically susceptible individual, when he is exposed to an environmental acquired condition, he develops the phenotype of the dilated cardiomyopathy. So dilated cardiomyopathy is the intersection of a gene mutation and an environmental acquired condition. And an important example for this is the peripartum cardiomyopathy, toxic cardiomyopathies like alcoholic and drugs such as chemotherapeutic agents, cardiac inflammation, which I mean by myocarditis, and metabolic disorders. So let's start with an introduction about the modes of inheritance. Modes of inheritance include monogenic disorders, polygenic disorders, oligogenic disorders. Monogenic disorders results from a modification from its name mono, a single gene, occurring in all cells of the body. So it's only a single gene. And this is a rare mode of inheritance, but it has a very large effect to cause a disease. Meaning it's rare for you to have this monogenic disorder, but if you have this gene mutation, it's very likely that you present with the phenotype of this disease. Monogenic disorders usually follow the Mendelian inheritance, which we all know it's the dominant or the recessive pattern. Polygenic is a trait determined by not one gene, many genes, and often environmental factors. Oligogenic is something between the poly and the mono. In cardiology, the most common form of monogenic that has Mendelian mode of transmission is the long QT syndrome. And the oligogenic is the dilated cardiomyopathy. Some of the dilated cardiomyopathy is inherited as Mendelian rules and with other modes of inheritance. So, dilated cardiomyopathy patients have positive family history in 30 to 50%. So, around half of patients with dilated cardiomyopathy have a family history of dilated cardiomyopathy. This explains the importance of the genetic etiology. And this genetic etiology to date more than 60 genes coding for the sarcomere proteins, the cytoskeleton, the nuclear envelope, and the sarcolemma and ion channels have been identified. So we have 60 genes that cause the dilated cardiomyopathy till now. These mutations are inherited most commonly as autosomal dominant, but there is X-linked and autosomal recessive transmission, also maternal transmission, mitochondrial disorders. The last point to say in this slide is the overlap between a genetic disorder and acquired disease becomes more and more ambiguous. What does this mean? A genetic disorder is a gene mutation that causes a disease. Acquired condition is something acquired from the environment, but they are very overlapping to the extent you cannot draw a sharp line to separate genetic from acquired in dilated cardiomyopathy. They interact together. So, to start with the mutations responsible for the dilated cardiomyopathy, we will start with the sarcomere proteins. Sarcomeric mutations, as we know that sarcomere is the contractile portion. It has the thick filaments, the thin filaments, and other proteins. The most common mutation is that of the protein named titin. Titin is a large spring-like protein, this one in orange. It stabilizes the thick filaments named the myosin. Between the thin filaments, the actin, to prevent overstretch and recoil of these fibers. So this is the function of the titin protein. What happens to the titin in patients with dilated cardiomyopathy is a mutation called truncation, titin truncation. It occurs in 13% of non-familial cases and 25% of the familial cases, and this is very common mutation. So, as we said in the beginning, does a certain genotype give rise to only a single phenotype? Meaning, if you have a mutation, you will have only one disease? No. You can have one mutation, and this mutation leads to different phenotypes. Let's take some examples for this. Beta-myosin heavy chain mutation as well as the alpha-myosin heavy chain mutation, both of these mutations can cause familial hypertrophic cardiomyopathy. They can also cause dilated cardiomyopathy and some features of restrictive cardiomyopathy. So the heavy chains are famous for the hypertrophic cardiomyopathy, but they can also cause a dilated phenotype. Another example is that a certain mutation can lead to dilated or hypertrophic, like the last example, but let's discuss it in details. The relation between something called the tension and sarcomeric calcium sensitivity on one side with the free cytosolic calcium on the other side determine dilated phenotype or hypertrophic phenotype. What does this mean? This means if you have, as shown in the figure, this blue one, if you have a high free cytosolic calcium and at the same time you have low tension and you have low sarcomeric calcium sensitivity, you will have a dilated phenotype. But if you have a high tension and a high sarcomeric calcium sensitivity on one side and you have low free cytosolic calcium, you will have hypertrophic cardiomyopathy. So they did an experiment in animal model and they did overexpression of a protein called troponin C. It's one of the thin filament sarcomeric proteins. They found that overexpression of troponin C causes to activate calcineurin and MEK1 ERK. So an overexpression of troponin C causes this change, calcineurin activation and MEK1 ERK activation. This activation of these two components led to the hypertrophic through increasing the sarcomeric calcium sensitivity and tension and decreasing the free cytosolic calcium. On the other hand, the troponin mutation also can cause calcineurin activation, but inhibition of the MEK1 ERK protein. This combination, activation of calcineurin and inhibition of MEK1, led to increase the free cytosolic calcium and decrease the tension and sarcomeric calcium sensitivity, led to dilated phenotype. So, one genotype, which is the troponin C mutation, led calcineurin activation with MEK1 activation, leading to increased calcium sensitivity and tension and decreasing free cytosolic calcium, led to hypertrophic cardiomyopathy. The same gene but another mutation, calcineurin activation, inhibition of MEK1, increase the free cytosolic calcium, decrease tension, and decrease sarcomeric calcium sensitivity, lead to dilated cardiomyopathy. So the same protein overexpression or another mutation led to different phenotypes, hypertrophic phenotype or dilated cardiomyopathy phenotype. Again, we talk about the dilated cardiomyopathy clinical spectrum. We said in the beginning the most common presentation is heart failure, and we have arrhythmia as an important presentation. But we will divide the clinical presentation in this slide into another classification. We will divide it into preclinical or early phase and the clinical phase. Preclinical or early clinical, it does not that the patient does not have symptoms. It means that preclinical of the typical dilated cardiomyopathy. Typical dilated cardiomyopathy includes dilated heart and hypocontractile function. So what is the preclinical phase? The first one is you just have the mutation and you have no cardiac symptoms. How you define this? This is a genopositive, he has the mutation, but a phenonegative, he doesn't have dilated cardiomyopathy. Then you can have just ventricular dilatation and no hypocontractility and so no symptoms. And also you can have the arrhythmic cardiomyopathy and just arrhythmia, no dilatation, no hypocontractility. Then you have the classic dilated cardiomyopathy, which is dilatation plus dilatation with hypokinesia or hypokinesia only without dilatation. So from this slide, I want to repeat and emphasize that dilated cardiomyopathy early in the course of the disease can present with only arrhythmia. So what is the genetics of this arrhythmic cardiomyopathy? Let's remember the most important gene mutations for arrhythmic genotypes in familial dilated cardiomyopathy, which are the lamin AC and the phospholamban genes. Why are these the most important genes? They are the most important genes because they have the highest risk of sudden cardiac death. So, practically speaking, if you have a dilated cardiomyopathy case, a genetic case that is presenting with arrhythmia, and you have the genotype of the patient that is lamin AC or phospholamban, you should put an ICD for this patient. It's a crucial thing. Other genes that are not important in regards of sudden cardiac death, but they are reported to have these mutations to present with arrhythmia: filament C, RBM2, and more recently the titin truncation variants may also present with arrhythmia. So here we have one phenotype, which is arrhythmic dilated cardiomyopathy. But how many genotypes have resulted in it? Around 6. Lamin AC, phospholamban, filament C, RBM, and titin. So several genotypes led to one phenotype, which is arrhythmic cardiomyopathy. At the same time, they found that mutations in the genes for desmosomal proteins, and if any one of you know, desmosomal protein mutation are very famous for the ARVC. So these desmosomal protein mutations can also cause dilated cardiomyopathy, not only ARVC. So this is a diagrammatic representation for this. It was published in 2019. On one hand, we have the dilated cardiomyopathy arrhythmia. On the other hand, dilated cardiomyopathy only, and on the other hand, we have the ARVC. In the middle, we have close to the dilated cardiomyopathy, arrhythmic dilated cardiomyopathy, and here left dominant ARVC. So all these genes can cause both phenotypes, can cause dilated or ARVC. But if you see the DSP, the DSG2, the DSCC2, these are desmosomal proteins, they have more propensity to cause ARVC, while the LMNA and lamin A and this lamin AC, these genes mutations are more likely to cause dilated cardiomyopathy. So desmosomal proteins can cause both, but more likely to cause ARVC. At the same time, these genes can produce both, but it's more likely to cause dilated cardiomyopathy. To conclude all this, one genotype can give several phenotypes. And also one phenotype, such as arrhythmia, can be related to several genotypes. For example, many genotypes, lamin A and C, desmosomal mutations and channelopathies can lead to arrhythmia. Again, desmosomal genes can lead to two phenotypes, ARVC, dilated cardiomyopathy, and sarcomeric mutation can lead to dilated, hypertrophic, or restrictive cardiomyopathy. So, this example, many genotypes led to one phenotype. This is one genotype led to two phenotypes. This is one genotype led to three phenotypes. So, to conclude, you can have it both ways. One genotype cause many phenotypes, one phenotype related to many genotypes, and this is the example of the cross-linking between them. After we talked about the gene mutation, let's talk about the two neuromuscular disorders we have, which are Duchenne muscular dystrophy. As we know, it's an X-linked genetic disorder diagnosed in childhood, most probably. Its incidence is like 1 in 5,000 live male birth. Because it's X-linked, only males can be affected. Caused by mutations in the gene encoding for the dystrophin protein. Absence of this dystrophin leads to cascade of events leading to progressive loss of muscles. Without supportive care, they usually die in their late teens or early 20s. Historically, the most common cause of death was respiratory failure, but recently, cardiomyopathy and heart failure is an important cause of morbidity and mortality in these patients. Regarding the diagnosis of Duchenne muscular dystrophy, you have motor signs and non-motor signs. You don't have to go through them all, but at least know the famous one: the calf pseudohypertrophy, the abnormal gait, inability, and the rest are due to proximal muscle weakness, like inability to jump, difficulty climbing the stairs, etc., 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 and to walking. Non-motor signs زي behavioral issues, cognitive delay, and failure to thrive, and learning abilities. So to diagnose Duchenne, if the patient have a family history of Duchenne muscular dystrophy, you will ask for any suspicion of abnormal muscle function. But if the patient does not have family history of Duchenne muscular dystrophy, but he has, you have a male that didn't walk till the age of 18 months. He has Gower sign on standing up. He has toe walking. If any of these factors are positive, you will have to test for the creatine kinase. If the creatine kinase is not increased, this is not a Duchenne. If it's increased, still we need confirmation. We will do testing for the Duchenne muscular dystrophy, the dystrophin gene mutation, which is deletion or duplication. Mutation is found, then we make the diagnosis. Not found, we do another genetic test called genetic sequencing. Mutation found, we diagnosed. Mutation was found, we go to the last step, which is muscle biopsy. What is absent from muscles in this disease, as we said, is the dystrophin. Dystrophin absent, we have Duchenne muscular dystrophy. Dystrophin present, it's unlikely. Consider alternative diagnosis. So to conclude, the treatment of Duchenne muscular dystrophy, it's a multi-specialty treatment. The most important specialty is the neuromuscular, not the most important, let's say the leading physician is the neuromuscular specialist. The role of the neuromuscular specialist is glucocorticoids and physiotherapy as a part of the rehabilitation management. Rehabilitation management also has occupational, speech, and language therapy. Also, these patients have impaired growth, delayed puberty, so they need endocrine management. They have gastrointestinal and nutritional problems. They need respiratory care, as we said in the beginning, and they need orthopedic care to maintain motor function for as long as possible. Regarding our specialty, the cardiac, it's a difficult algorithm and I don't think we need to go through it all, but let's say if the patient is asymptomatic, then annual. If symptomatic, we need more screening. You will treat him as a case of heart failure due to dilated cardiomyopathy, including the ACE and the ARB blockers. Late, you will go to the non-advanced heart failure treatment for the patients. If the patient is undergoing a non-cardiac surgery, you have to tell the anesthesiologist that he has Duchenne because this is a high-risk patient. So Duchenne muscular dystrophy, as we said, is the most severe clinical symptoms. Becker is more or less close to the presentation of Duchenne. The difference is it has a milder clinical course than Duchenne. So by this, we concluded our talk about the genes in dilated cardiomyopathy. And if you remember, we talked in the beginning about the modes of inheritance: monogenic, polygenic, and oligogenic. Then we talked about the different gene mutations. The most common was the titin truncation. Then we said that same genotype can lead to different phenotypes and same phenotype can be related to different genotypes. Then we talked about the arrhythmic cardiomyopathy, and we remember the layman A and C for the arrhythmia because they are associated with increased risk of sudden cardiac death. And then we concluded with the Duchenne muscular dystrophy and the Becker myopathy, the muscular dystrophy. Let's talk about the diseases, the subset of patients with dilated cardiomyopathy that are caused by genetic predisposition in addition to environmental factors, acquired factors. One of the most important examples is the peripartum cardiomyopathy. The peripartum cardiomyopathy, let's say that most genetic dilated cardiomyopathy, not the peripartum, the most genetic dilated cardiomyopathies usually manifest after puberty. This indicates that these patients have a hormonal change or require a hormonal change to develop the phenotype. One of the most important examples for the combination of genetic predisposition and hormonal changes to cause a disease is the peripartum cardiomyopathy, genetic, hormonal. But you also see viral. The viral role in dilated cardiomyopathy is questionable, meaning we are not sure of it. and I'll discuss later in the presentation why. So let's start with the genetic predisposition in patients with peripartum cardiomyopathy. The first factor, genetic in peripartum cardiomyopathy. This is an article from the New England Journal of Medicine. Why we say the patients with peripartum cardiomyopathy have genetic predisposition. First, it's more frequent in certain geographical regions. For example, in Africa, it's 1 in 100 to 1 in 1,000 pregnancies, or Haiti, this is very common rate. It's 1 in 299 pregnancies. Also, some patients with peripartum cardiomyopathy have clear family history of heart failure. The most important in this trial, the scientists actually isolated and recognized gene mutations like those we find in the dilated cardiomyopathy, including the most common one, the titin truncation, the myosin beta and alpha heavy chains, the troponin C, the troponin T, all these mutations. So peripartum cardiomyopathy has a genetic predisposition. What about the viral cause? Biopsies from the hearts of patients, female patients with peripartum cardiomyopathies showed Epstein-Barr virus, human cytomegalovirus, human herpes virus, together collectively we call them herpes viruses, and the parvovirus B19. These viruses were found in 30% of the cardiac samples in peripartum cardiomyopathy. But again, we will talk about this. Are these viruses a cause for peripartum cardiomyopathy, or they are just innocent bystander? I will discuss the answer later, but actually they are most probably an innocent bystander in 90% of the cases, but we have to describe them. The newest finding and the new discovery is the hormonal part of the peripartum cardiomyopathy. Studies found that in patients with peripartum cardiomyopathy there is unbalanced oxidative stress. This unbalanced oxidative stress activates an extracellular peptidase named caspsin D. This peptidase, it will cleaves what? The prolactin, which is the hormone of near the late pregnancy and delivery. Why? For lactation. And breaks the prolactin into 16 kilodalton fragment. This fragment promotes apoptosis in the endothelial cells and drive the progression of peripartum cardiomyopathy. So, this discovery led to a disease-specific treatment in peripartum cardiomyopathy. So, we found that in the process, the prolactin hormone is important. So, the treatment will include bromocriptine, which is a prolactin blocker. As a part of a regimen called the BORD, the bromocriptine and the oral heart failure drugs, anticoagulation, and diuretics. So, peripartum cardiomyopathy has a genetic role, as we said. It has a hormonal role, prolactin, and so we can use bromocriptine in its treatment. And it has an unsure viral cause. After this, let's talk about the cancer-induced cardiomyopathy. They actually found that some patients are more vulnerable to have cancer-induced cardiomyopathy more than others, although they took the same drug. And the explanation for this was first explanation, they found that there is titin mutation, like that found in the dilated cardiomyopathy. So the genotype, sometimes the titin mutation, along with the cumulative chemotherapy dose and traditional cardiovascular risk factors, all these can lead to cancer-induced cardiomyopathy. The same is for alcohol, and the same mutation, titin truncation, was found in patients with alcoholic cardiomyopathy. Actually, this trial showed the effects on the baseline ejection fraction. This is the baseline ejection fraction of the patient, 0. This is the effect of titin truncation, see here, on these patients. And this is the effect of alcohol, here, on this. When we combine the titin truncation and the alcohol, see what happens to the ejection fraction? It's here, titin truncation and alcohol. The ejection fraction decreased around 10 to 15% from the baseline. After this, we talk about the inflammatory conditions. Surprisingly, in this trial that was published in the JACC, they found that homozygous rare variants associated with inherited cardiomyopathy were found في عيانين acute myocarditis و acute viral myocarditis، وده explains القصة دي. To conclude الحتة دي كلها in let's say that the patients should have genetic susceptibility. On top of this genetic susceptibility, they develop an acquired condition. For example, pregnancy with its hormonal changes, including that of the prolactin, to develop dilated cardiomyopathy. Genetic predisposition, and they drink alcohol, so they have alcoholic cardiomyopathy. And they take chemotherapeutic agent with a cumulative dose effect, so they will have dilated cardiomyopathy. They develop myocarditis, so they have dilated cardiomyopathy, etc., etc. This was described in Circulation 2017 called the second hit model. So we finished the genetics and we finished the combination of genetics and acquired conditions, and this is our conclusion. Family history is positive in 30 to 50% of cases with dilated cardiomyopathy. The most common gene involved is titin truncation. Single genotype can cause multiple phenotypes. Single phenotype may be related to multiple genotypes. Dilated cardiomyopathy at the intersection of genes acquired conditions is common as in peripartum cardiomyopathy and alcoholic cardiomyopathy. So we finished the first part of this presentation, which is the genetic causes for dilated cardiomyopathy. Sorry. Let's talk about the next section, which is the infection. This is the question I have been asking from the start of the presentation. Are viruses innocent bystanders or not in cases with dilated cardiomyopathy? Let's start with what is viral infection. What does it cause for the heart? The viruses affect the heart in two ways, or both. The first way is direct myocardial injury. It's simple. The virus causes apoptosis and necrosis by itself. Or it activates the immune response. These days we have the COVID-19 era. We hear about the cytokine storm that happens in this from this virus, and it's the cause of a lot of its manifestations. So it's either innate or acquired. So viruses cause this immune response, and this immune response could cause autoimmune myocarditis. So whether the virus caused direct myocardial injury or immune response or both, we have to know the outcome. Resolution, everything is back to normal, or the myocardial injury stays and the autoimmune myocarditis stays and causes dilated cardiomyopathy. I have one point to add that the autoimmune myocarditis and the immune response could continue after the virus is cleared by the body, and you still have the effect on the heart. So the question, again to repeat, when you have a biopsy, endomyocardial biopsy from a patient with dilated cardiomyopathy or myocarditis, and you find a virus, is this virus the cause for this myocarditis or not? We will answer this question. Again, this slide we took before, that patients have genetic predisposition, have the viral myocarditis. Let's talk about the different viruses that are famous to cause myocarditis. This is the history of their discovery. We have the enteroviruses, Coxsackie A or B, adenoviruses, human herpes virus 6, parvovirus B19, hepatitis C, and Epstein-Barr virus. To know that enterovirus and adenovirus can be cleared, so you will not often see them in the biopsies. The rest cannot be cleared. You will find them in the biopsies. So let's start with the Coxsackie virus B and adenoviruses. These viruses are not bystanders. This is the first type that we say clearly they are not bystanders, meaning they can cause myocarditis. How they do their effect, as we said, direct effect on the heart, and they act on the heart through a receptor called CAR, Coxsackie and adenovirus receptor, وده موجود على cardiomyocytes. Experimental inhibition of this receptor in an animal model prevented enteroviral induced myocarditis. They can induce an uncontrolled also immune response. So Coxsackie B and adenovirus, they are not bystanders. This is number one. Number two, they harm the heart in both ways, direct injury and the immune response, okay? And this direct injury through the receptor called CAR. Next, we talk about the virus that is common in Egypt, and its prevalence is decreasing, is the hepatitis C virus. 45% of patients with hepatitis C virus develop heart failure. Hepatitis C can induce directly and indirectly myocarditis. So again, hepatitis C is not an innocent bystander. But you see a lot of hepatitis C patients that do not have dilated cardiomyopathy. So again, it's dependent on the background of the patient, genetic predisposition as we are repeating, and it's dependent on the serotype of the hepatitis C virus. And the hepatitis C can be cleared with the directly acting antiviral based treatments. Let's talk about the herpes viruses, cytomegalo, Epstein-Barr, and the HHV6. If you took a sample from the population, you will find that most of the population are infected with these viruses at least once in life. So they are infected once in life. So what is the problem? The problem is that they are here to stay. They cannot be cleared, as we said before. They have a latent persistence. So mostly they are bystanders. If you took a biopsy from your heart right now, you can find one of the herpes viruses in it. But you don't have dilated cardiomyopathy because they have cardiotropism. So are they always bystanders, or sometimes they can cause dilated cardiomyopathy, sometimes they can cause cardiomyopathy? How we know if these viruses caused dilated cardiomyopathy? We know from the evidence of replication in the blood. If you find a lot of copies of the virus in the blood, in addition to you take an endomyocardial biopsy and you find extensive inflammation in the myocardium, then you can say that these viruses caused the disease. So in 90% of the cases, they are bystanders. In 10%, they could be the true cause for the dilated cardiomyopathy, and we said how to identify it. Why is it important to identify if they are the cause? Because if they are the cause of dilated cardiomyopathy, the patient will need steroids in addition to the antiviral treatment, according to the type of the virus. About the parvovirus by B19, it's the same like the herpes viruses. Again, actually it's present in everywhere in your body if you take biopsies in the DNA. In the bone marrow, brain, kidney, liver, lung, lymph node, testis, thyroid, tonsils, everywhere have parvovirus B19. So it's a latent virus. It has long life persistent, mostly bystander. Only if you find in the blood high DNA copies, you think of it as cardiotoxic virus. After this, let's talk about the influenza-associated myocarditis. It causes acute fulminant form of myocarditis. It's rare, but the true prevalence is not known. The treatments for influenza-associated myocarditis is hemodynamic and ventilatory support, beside الأدوية اللي كلنا عارفينها neuroamidase inhibitors زي التاميفلو وغيره. In 2009, there were 58 reported cases of myocarditis associated with the H1N1 pandemic in Japan. This year, the COVID-19, there were multiple reported cases of myocarditis in several. This is one example of it. So the conclusion of the question: are the cardiac viruses innocent, bystander, or not a bystander? To begin with, adenovirus and Coxsackie B3, they are virulent and they are not bystander for sure. Hepatitis C, it's virulent if you have a patient that is HCV positive and he has heart failure, dilated cardiomyopathy. Treats independent of the endomyocardial biopsy result. If the endomyocardial biopsy is negative, still treat for HCV. Then you have the group of Epstein-Barr, HHV viruses and the parvovirus B19. 90% of the time they are bystander. But sometimes you can find them in the endomyocardial biopsy and needs to be treated if you find high copies and viremia in the blood. The same applies to the influenza virus. So we ended the virus section. Then we talk about the systemic immune. We will go through it rapidly. This is a nice paper, but we will not go through it, from the ESSC about management of myocardial involvement in systemic immune-mediated diseases. I want to emphasize on the definition and the difference between autoinflammatory disease and autoimmune disease. Autoinflammatory disease, from its name, there is an unexplained inflammation. But this unexplained inflammation has no problem in immunity. So unexplained inflammation, no problem in immunity. Unprovoked inflammation in the absence of high autoantibody titer or reactive T lymphocytes. Differing from autoimmune disease that they have a problem with immunity, whether the cell-mediated type or the autoantibody-mediated response. So this paper classified the autoinflammatory and the autoimmune. They classified the autoimmune into rare monogenic disease and the classic polygenic autoimmune disease like the rheumatoid, celiac, primary biliary cirrhosis, myasthenia, etc., etc. And the autoinflammatory, again, rare, monogenic, the polygenic, those are the famous Crohn's, gout, arthropathies, etc., and the mixed pattern like reactive arthritis, psoriasis, and ankylosing spondylitis. So the main item I want to differentiate between them now is that we have autoinflammatory, just inflammation, unexplained, with no immunity problem, autoimmune, a mainly immunity problem. Each of them will be divided into rare monogenic and the classic polygenic diseases. Again, the toxic like alcohol, the drugs like the chemotherapeutic agents, the diabetes, etc. We will not go through them now, but let's remind you that to have this, patients usually have to have genetic predisposition, especially of titan truncation. What about the natural history and outcome of heart failure in dilated cardiomyopathy? So, dilated cardiomyopathy patients, either they will have improvement in the symptoms and improvement in the ejection fraction, or they will have improvement of the symptoms and stabilization of the ejection fraction, or they will proceed to advanced heart failure and transplantation or even death. So what affect the patient to go through either ways, this way or this way or this way? This natural history is affected by, first, the treatment you give to your patients. The guideline-directed medical therapy, the ICD, the CRT, also the mechanical circulatory support, all have provided further improvements in outcomes of patients with dilated cardiomyopathy. And actually, when they tried in a recent trial called the TREAD heart failure, that included, it was a small trial of 51 patients, they brought the patients with dilated cardiomyopathy and who had improvement in the LV function back to normal and tried to withdraw the guideline-directed medical therapy. They were surprised that 40% relapse of the LV dysfunction, not the symptoms, the LV dysfunction within 6 months. So continue heart failure treatment even in recovered cases. Okay. So what are the good predictors? The good predictors, we say that they are the predictors of reverse remodeling. Reverse remodeling is a good thing. Why? Because reverse remodeling was associated with 50% lower mortality rates at 10-year follow-up in dilated cardiomyopathy patients. So what are these predictors? There is a trial called Improve Heart Failure that said that female, sex, no prior myocardial infarction, non-ischemic heart failure etiology, no digoxin use, were actually predictors of LV functional recovery. For the echo, high baseline ejection fraction and lower endodiastolic diameter were predictors of reverse remodeling. And in the CMR, lower extent of late gadolinium enhancement indicative of lower interstitial replacement fibrosis was a predictor of reverse remodeling. So, female sex مفيش اسكيميا قبل كده، مفيش ديجوكسين، ejection fraction عالي، endostolic diameter قليل، and مفيش late gadolinium enhancement. دول good predictors. طب العكس بتاعهم هم الباد predictors اللي هم عكس الفيميل sex is the male sex ومعاها الادفانسد ايج اكتر من 60 سنه ومعاها higher NIHA classification و self declared black race. So male more than 60, higher NIHA, self declared black race. ECG showing left bundle branch block, high natriuretic peptide levels, low ejection fraction, severe functional mitral regurgitation, and finally mid-wall myocardial late gadolinium enhancement. These are predictors of poor outcome. So, as we said in the beginning of the natural history, this slide, that the guideline-directed medical therapy is the thing that improved the outcomes in patients with dilated cardiomyopathy. So what is the guideline-directed medical therapy? ACE and ARBs, beta blockers, mineralocorticoids, ivabradine, digoxin, sacubitril, valsartan, CRT, and treatment of severe functional mitral regurgitation. In addition to treatment of arrhythmia and prevention of sudden cardiac death, remember the lamin A and C, ICD, CRTD, beta blockers, amiodarone. After this, we will talk about an interesting and last part of this presentation, which will be the etiology-related therapies. So, these are the famous outcome trials for heart failure with reduced ejection fraction. All of these trials had a percent of patients with non-ischemic dilated cardiomyopathy. So, if we look to the landmark trial for the enalapril, which was the Solvid, 18% had dilated cardiomyopathy and reduced mortality in this 18%. If we go for the beta blocker, the CIBIS, in 1994, for bisoprolol, 36 patients had non-ischemic dilated cardiomyopathy and reduced all-cause death. If you go to the CHARM alternative for the candesartan, 20% had non-ischemic dilated cardiomyopathy. If we go for the mineralocorticoids, the rails for the spironolactone, the emphasis heart failure for the eplerenone, in the rails 46% had non-ischemic, and in the emphasis 32%, and reduced cardiovascular death and hospitalization. Also, ivabradine in the shift 33 had dilated cardiomyopathy, and finally, the paradigm heart failure for the Entresto had 40% dilated cardiomyopathy patients. So, to go out of these slides, all these drugs that proved mortality benefit in the heart failure ischemic type, they are useful in the dilated cardiomyopathy phenotype. What about the device therapy? What about the ICD? The ICD, when compared in trials, it actually decreased both the all-cause mortality and the arrhythmic mortality or the sudden cardiac death. Except for the definite trial, it didn't decrease the all-cause mortality. And actually, in this companion trial, we compared CRTP versus placebo and CRTD versus placebo. CRTP alone, without ICD, it was significant to decrease the mortality, all-cause mortality. And adding an ICD actually improved the significance in the companion trial. But the Danish registry led to different results. Danish trial was a big trial. It included 1,116 patients, followed up to 67 months. We use ICD or not in patients with heart failure with reduced ejection fraction, dilated cardiomyopathy. The surprise here was that unlike the previous studies, it was not associated with all-cause mortality benefit. They explained that it failed to improve mortality for two reasons. The first reason is that 60% of the study population had CRT. So CRT actually decreased the sudden cardiac death, so it didn't show a benefit for the ICD. The second explanation was that when they talked about the younger patients, less than 70 years, actually there was a mortality benefit. So CRTP or CRTD في عيانين Dilated Cardiomyopathy. The answer is الجايدلاينز قديمة شوية بتاعة الهارت فيلير بتقول prophylactic ICD implantation for primary prevention is recommended if the ejection fraction is less than 35 with heart failure manifestations. But this recommendation was based on the earlier clinical trials that demonstrated decrease in the arrhythmic and the all-cause mortality اللي هم definite SCD HEFT trial companion trial. The results of Danish trial, in which أكتر من 50% had CRT, have shown that ICD implantation reduced the risk of sudden cardiac death with no significant effect on all-cause mortality. وده عكس companion trial اللي ورد significance أكتر. So this underscores and proves the need for a good risk stratification. So when you have a patient eligible for a CRT, for dilated cardiomyopathy, should you use in this patient CRTP only or CRTD in addition to this? So we need to improve our risk stratification. In addition, why we should do this? Because when you implant only a CRTP, it leads to reverse LV remodeling, which significantly lower the risk of sudden cardiac death. After we talked about the guideline-directed medical therapy, and we said it's the same recommendations as the heart failure, and we talked about the ICD, and we concluded that the guidelines said we should implant it despite the Danish trial, which is later than the guidelines. We will talk about the functional mitral regurgitation. Two trials have two contradicting results, which are the MITRA-FR trial. The MITRA-FR the heart failure hospitalization didn't differ significantly between the patient who have percutaneous treatment for the mitral regurgitation or who didn't have. Conversely, in the coapted trial, patient treated with percutaneous edge-to-edge repair actually had reduced heart failure hospitalization and reduced mortality. The coapted trial was published in 2018. It included 614 patients. They were symptomatic, ischemic or non-ischemic, ejection fraction from 20 to 50, and systolic diameter less than 70 millimeter. They had either moderate to severe or severe functional mitral regurgitation. They decreased both the mortality and the hospitalization. An explanation why the MITRA-FR failed, unlike the coapted trial, is that the type of patients in the MITRA-FR were more advanced compared to the coapt, implementing that if you targeted the mitral valve earlier, this could be associated with more benefit. After we talked about the guideline-directed medical therapy, the device therapy, and the functional mitral regurgitation, let's go to the end stage, the advanced heart failure. As we all know, the definitive treatment for the advanced heart failure is transplantation. Dilated cardiomyopathy is the leading indication for heart transplantation in adults and children. Actually, more than 40% of the recipients اللي عندهم long-term mechanical circulatory support بيبقوا dilated cardiomyopathy. أهمية الترانسبلانتيشن في إنها ال 1 year survival بتاعها is very high 90%, and the median survival بتاعها في عيان 12 years. يعني عيان كان خلاص advanced heart failure and very close to death, he lived an additional 12 years. So final thing in this presentation will be the etiology-related therapies in dilated cardiomyopathy. There are 3 points. The first one is immunosuppression. This immunosuppression is an evolving field that needs further evidence from the clinical trials. Who are the candidates to receive immunosuppression? All dilated cardiomyopathy patients? No. You have to use this immunosuppression in patients that have dilated cardiomyopathy post-myocarditis. Any post-myocarditis? No, virus negative. So you have three criteria: dilated cardiomyopathy, post-myocarditis, not due to virus negative. Okay. What is the type of immunosuppression you will use? Azathioprine in addition to prednisone for 6 to 12 months. Where immunosuppression is also recommended in giant cell eosinophilic myocarditis and cardiac sarcoidosis. The Epidemic trial in 2009 showed a benefit from the azathioprine steroid combination for 6 months in this category virus negative inflammatory cardiomyopathy, but this field needs more and more trials. The second etiology-related therapy in dilated cardiomyopathy is immunoadsorption. Immunoadsorption is some sort of plasmapheresis. You remove the specific antibodies and the immune complexes and keep the rest of the plasma. Just a pilot study has been done and we are waiting for more and more trials. The final thing for etiology-related treatment for peripartum cardiomyopathy is bromocriptine. As we remember that in the development of peripartum cardiomyopathy, you have a hormonal imbalance, which is the prolactin that is broken into a particle. This particle causes the peripartum cardiomyopathy. And so you have to inhibit this process by blocking the bromocriptine. In this trial, they compared no bromocriptine at all versus for 1 week versus for 8 weeks. And they found that the ejection fraction improved and the mortality decreased in patients who received bromocriptine. But there was no difference between to use bromocriptine for 1 week or to use bromocriptine for 8 weeks. This is my last slide in this presentation. It's about the etiology-related therapies in dilated cardiomyopathy. It's the gene repair. For sure, this is the future, especially in the monogenic causes. And one famous successful mode is that used in Duchenne muscular dystrophy, which is the CRISPR-Cas9 technology, but this field is for more and more trials. Here comes to an end of my presentation. I hope that you all have benefited from this lecture. Thank you and have a good day.